Before we begin, a quick but important note. Everything discussed on this podcast is for educational purposes only and does not constitute medical advice. So if you or a loved one is navigating cancer treatment, please work closely with your oncologist, your pharmacist, and healthcare team before making any decisions about cannabis or any other supplement. So now let's get into it. Welcome to When Food Meets Medicine, the podcast where we explore the relationship between what we consume and how medications work, so you can make smarter, safer choices for your health. I'm your host, Dr. Remi Olukoya, and today's episode is one I've been looking forward to for a long time. And I believe it would be one of the most important conversations we've had on this show. We're talking about cannabis and care, not in a vague, feel-good way, but specifically what the science actually say. How does cannabis interact with chemotherapy drugs? What is the difference between CBD and THC? And does it matter which one a cancer patient uses? Can cannabis actually reduce nausea, pain, and anxiety during treatment? Or is that mostly anecdote? And perhaps most critically, why are many cancer patients using cannabis without telling their oncologist? And what happens when those two collide in the body? These are not hypothetical questions. Right now, studies suggest that between 25 and 40% of cancer patients are using some form of cannabis during treatment. Most of them are not telling the medical team. And as a pharmacist, that statistics keeps me up at night. That metabolize most chemotherapy drugs. So today, we're going to have the kind of honest, evidence-based conversation that cancer patients deserve to have and rarely get. Abrams is a professor of clinical medicine at the University of California, San Francisco, and an integrative oncologist at the UCSF Usher Center for Integrative Health. He's been studying the clinical use of cannabis in oncology since the early 1990s, at a time when that was not a career-friendly decision. He conducted some of the first FDA-approved clinical trials on cannabis in the United States, and he has spent 3 decades building the evidence base that cancer patients and clinicians now rely on. Dr. Abrams, welcome to When Food Meets Medicine.
It's a pleasure to be here. Thank you for having me.
So it's wonderful to have you here. And to our listeners, if you are new to the show, this is exactly the kind of conversations we are going to be having every week. So each subscribe right now so you never miss an episode. So now, Dr. Abrams, I want to start at the beginning because your story is remarkable, and with the audience to know when you began researching cannabis in oncology in the early 1990s, at a time when the medical establishment was deeply resistant to even having that conversation. So take us back to that moment when, what made you pursue this and what did you face when you did?
Well, first of all, I did go to college in the 60s and I went to Wood. So, cannabis was not something that I was fearful of. I also live in San Francisco and California, and we have also been very embracing of cannabis, certainly as a recreational agent for quite some time. At the beginning of my training to be an oncologist, suddenly AIDS came out of the blue, and we didn't know what it was or what to do about it. And it was a very devastating disease. And at the beginning, many of our patients who died of the so-called AIDS wasting syndrome found that cannabis was useful for increasing their appetite. In fact, we had a woman working at the AIDS clinic as a volunteer named Mary Rathbun, who was Volunteer of the Year 2 years in a row. She used to wheel our patients to X-ray and drop off their prescriptions in the pharmacy and also bake them brownies, special kind of brownies. So she was known as Brownie Mary. And in 1992, the AIDS conference, the International AIDS Conference, was being held in Amsterdam. And I glanced at CNN headline news, and there was Brownie Mary being arrested for baking brownies. So when I got back to San Francisco General, there was a letter addressed to the director of AIDS research, suggesting that a clinical trial showing the benefits of marijuana should come from Brownie Mary's institution,
Yes.
as
Oh,
if she
wow.
were our dean. So I picked up the gauntlet and I said, okay, I can do that. I went to college in the 60s. So it began a 5-year fight with the federal government to get
Wow.
myself allowed to study marijuana. And finally, I did what my partner calls a Trojan horse study, because what I learned during this whole time was that the only legal source of marijuana for research was NIDA, the National Institute on Drug Abuse. And
Mm.
NIDA has a congressional mandate that they can only study substances of abuse as substances of abuse. So
Wow.
my attempt to study marijuana to see if it would benefit these AIDS patients was never going to work out because
Mm.
we can't study benefit. So instead, in 1996, protease inhibitors first became available as effective antiretroviral agents. So
Yeah.
I said I wanted to see if it was safe for patients on protease inhibitors to add cannabis because of a potential drug mechanical interaction.
Yeah.
And as long as I was looking for potential harm, I was able to get $1 million and
Fund.
1,400 of the government's finest marijuana cigarettes to study in patients with AIDS on protease inhibitors. So that
Oh,
was the beginning.
that is so interesting. The overlap, not knowing that that was where for Mary, you would never have thought that it would start from there. I think the lessons from HIV patients normally start to inform what impacted when Mary was using it for cannabis patients. Sorry, for cancer patients.
So I've been an oncologist now for 43 years, and cannabis has always been accessible in San Francisco, and it became legal for medical use here in 1996. So
Mm.
that's now 30 years we've had cannabis available to patients. And during the course of my career, I would guess that 40 to 50% of the people I see have used cannabis and they benefit from its use.
Mm.
I mean, not everybody does. Not everybody benefits from taking Tylenol. So, it's just, it's probably depends on genetics and your cannabinoid receptors, but I have seen patients with cannabis, cancer patients, use cannabis and not use antiemetic therapies. As you
Mm.
know, the standard antiemetics that we use in cancer patients are very constipating.
Yeah.
And I think if you have cancer and if one of your bodily functions stops, that's very frightening because you feel
Yeah.
like you're dying or part of you is dying. So
Mm.
the fact that many of my patients forego the use of ondansetron while they're getting chemotherapy in favor of using cannabis is something that makes them feel better.
Mm.
So that cannabis has been known to have antiemetic activity for, it was dronabinol is delta 9 tetrahydrocannabinol that was
Mm.
licensed and approved for
Yeah.
chemotherapy induced nausea and vomiting in 1986. So that
Yeah.
was 40 years ago.
Mm.
So,
It's a
and
long time.
why did they choose to study dronabinol? Because cannabis worked. The pharmaceutical companies were looking for something that they could patent and make available as a medicine.
The medicine. But what now explains why we seem as if we're playing catch up scientifically? Because the stigma seems to delay the research by years, and that means patients today are making decisions with incomplete information. So I want us to fill in some of these gaps. We'll talk about cannabis actually, because I think CBD and THC are two of the most misunderstood terms in medicine right now. So could you explain CBD, THC, and the methods in which they are used today?
Well, yeah. So first of all, I am a proponent of the plant. I think nature did it best. The plant cannabis has probably 400, 450 chemical compounds, and about 120 of those are so-called cannabinoids, 21 carbon terpenophenolic compounds that have medical effects. And the one that's most widely known is delta 9 tetrahydrocannabinol, or THC. And it's most widely known because it is what makes people get high. And the way that works, we and all animal species have a system of cannabinoid receptors. The cannabinoid 1 receptor is the most densely populated 7 transmembrane domain G protein coupled receptor in the human brain. But they don't teach us about that in medical school. Shows you
Mm,
the extent of reefer madness that we don't teach about the most
mm,
densely recepted receptor in the brain. we and all animal species down through sea slugs have these receptors. Why? You've never seen a monkey smoking a joint. It's
No.
because we also make our own endogenous cannabinoids. Just like we make our endorphins, our endogenous opioids, we also make endogenous cannabinoids. And it's theorized that the reason we make them is to help us to forget, and particularly to help us to forget pain.
Mm.
So, not surprisingly, cannabinoids are also, or cannabis is also useful, in my opinion, for pain. So, as I mentioned, delta 9 THC was isolated and made into a medicine in 1986 for chemotherapy induced nausea and vomiting. But it's very different from the plant because the plant has 400 other compounds to sort of balance the effect of the THC. And one of
Mm.
those is another cannabinoid called cannabidiol, or CBD, which has become very popular because it doesn't get you high. You can't say that it's not psychoactive because people who use it say that it helps them sleep and it decreases anxiety. So to
Yeah.
me, that speaks that it must be psychoactive. I think CBD also is present in the plant to diminish the effects of THC. And I think in the
Mm.
current products that people are accessing in dispensaries, the
Yeah.
CBD is there to decrease the high associated with THC. And in my opinion, it also decreases the benefits.
Mm.
So I am not a big
Interesting.
fan of CBD. I'm not sure that it really does much.
Patient. So when a cancer patient walks into a dispensary or goes online and sees CBD oil or THC capsules or edibles, it is overwhelming. So, but from a clinical standpoint, what is the most important distinction a cancer patient needs to understand? I know you explained that, but for the three, the CBD and THC, which one would you think is better for a cancer patient?
Yeah, again, I don't think either one of those are good. I like the plant. Cannabis is a botanical that's been used by people for 3,000 years. And so the whole plant gives you the so-called entourage effect because in addition to those two cannabinoids, the plant has terpenoids, which are biologically active and also give each plant, each species, its characteristic aroma. And it also has flavonoids, like are present in my apple, that are also, clinically beneficial. So the plant, in my opinion, is the medicine. The THC, I did a study in AIDS patients where one group smoked marijuana, one group got dronabinol, and one group got dronabinol placebo. And they were
Mhm.
in our general clinical research center for 21 days and nights. And the patients smoking marijuana were happy and up and cleaning their room, and the people getting 2.5 milligrams of dronabinol 3 times a day stayed in bed the whole day sleeping. So
Mm.
clear to me that it's a different medicine. Now, CBD has become increasingly popular because it doesn't get you high. We live in a puritanical derived culture with Judeo Christian beliefs that being euphoric is not a good thing.
Mm.
So that's why people are gravitating towards CBD because it
CBD.
doesn't give you euphoria. I think if you're a patient with cancer, there's no problem having your mood elevated,
Yeah,
you know.
because you're in
And
pain already. Yeah.
they did a study in end stage cancer patients, giving them increasing dosages of oral CBD up to 300 or 400 milligrams a day,
Mm-hmm.
and they did it as a placebo controlled trial. CBD did nothing for those patients with regards to quality of life or any of their symptoms. And I'm not sure that CBD is anything more than hype. In fact, they did a
Mm.
study where they did an experimental pain model on people. And there are only 15 people, but they got CBD or placebo. And they were told your CBD is either CBD or they were told it was placebo. And they were told the placebo was CBD or placebo. And the patients who took the placebo and were told it was CBD had more relief of their pain than the people who took the
Wow.
CBD. So
Yeah.
to me,
Yeah.
that's expectancy.
Yeah.
And, when I go to the checkout stand in my Whole Foods, you
Yeah.
can buy CBD at 10 milligrams. 10 milligrams, the studies that
Yeah.
showed any benefit were 600 milligrams.
It's
I don't
nothing.
believe CBD is, I think nature
Anything.
does the best, and the plant is the best medicine, in my opinion.
Okay. So let's talk about cannabis. Cannabis consume. Because I think this is why, from what you said, the reduced dose 10 to 600. So I think where patients make a lot of mistakes, the edibles, the smoking, the vaping, the pharmacokinetics are completely different from each one. So what do
Totally.
you patients who ask which method to use on this ones apart from the real thing, the lead?
Excellent question. Excellent question. So we did some pharmacokinetics of oral versus inhaled cannabis. When you inhale cannabis, excuse me, when you inhale cannabis, peak plasma concentration of the THC is reached in 2.5 minutes, and then it dissipates quite rapidly after that. When you take THC or cannabis by mouth, it takes 2.5 hours for the peak concentration, which is much lower. However, when cannabis is taken by mouth, it gets metabolized in the liver to an even more psychoactive 11 hydroxy metabolite. So that's why I see a lot of older women with cancer, particularly, who think eating is good and smoking is bad.
Right.
So they go to the dispenser and they're told only eat a quarter of the cookie. And they do, and nothing happens. So they eat another quarter and nothing happens. So they eat the whole cookie. And then they call me 3 days later, perhaps after a visit to the emergency room, with a dysphoric reaction saying, I'm never going to do that again. So I tell patients if they want better control over the onset, the depth, and the duration of the effect, that inhalation is probably better than oral administration. Also, as an oncologist and as an integrative oncologist with a real interest in nutrition, I don't think sugar is good for people living with cancer. And gummies and edibles are always sugar. Now we have tinctures. And if you put a liquid in your mouth, you immediately absorb some from under your tongue sublingually, which reproduces the kinetics of inhalation, and then you swallow the rest. So you get hybrid pharmacokinetics if you take a tincture. So that's what I'm more likely to recommend to patients. If patients want to smoke, I don't worry about a joint so much, but I do recommend either a vaporizer or a water pipe, a bong. I'm not a fan of vaping, which is inhaling an oil. As an oncologist, I'm pretty conservative, and I know the long-term effects of inhaling a plant, but not the long-term effects of inhaling an oil. And I think we've already seen that there is some lung damage that can be a consequence of that.
Yes. I think I like the way you explain it because the kind of nuance that gets lost when people Google cannabis for cancer. And it leads me to the next question that I think is most important from a pharmacy perspective, because this is where patient safety really lives. So we're going to talk about drug interactions, the cytochrome P450 conundrum, where cannabis and drug interactions. So, as a pharmacist, this is the segment I want every cancer patient and every oncologist to hear. Cannabis, both CBD and THC, is metabolized through the cytochrome P450 enzyme system. And that is the same system that processes the majority of chemotherapy drugs, anticoagulants, antiemetics, which you had mentioned, and many of the supportive medications cancer patients take. So, Dr. Abrams, can you walk us through what that actually means in practice? What happens in the body when cannabis and chemotherapy meet?
Well, that's a great question that I don't think we really have many answers to. The only pharmacokinetic interaction study I'm aware of is one of cannabis tea and irinotecan and docetaxel. And not many of my patients are drinking a cannabis tea. So that's not really something that I believe in. And otherwise, it's very hard to do pharmacokinetic interaction studies of this sort because every patient getting this chemotherapeutic agent, and most patients don't just get one agent anymore, they get usually combinations of chemotherapy. Are you going to subject them to inhaling cannabis or drinking a cannabis tea or taking a tincture while they're being treated for cancers? I've done 2 pharmacokinetic interaction studies. The first one I mentioned in AIDS patients on protease inhibitors, and we also did a study that was aimed at cancer patients on sustained release opioids to see if vaporized cannabis changed the pharmacokinetics of their analgesic. But just like with the other studies that I've done in cancer patients, I found it impossible to enroll. All of our studies at San Francisco General, when I was there doing them, were inpatient studies in our General Clinical Research Center, requiring patients to stay there for up 5 to 25 days. And one of our symptom management nurses told me that cancer patients don't really want to spend extra days in the hospital because they suspect that they're going to wind up spending quite a few towards the end of their life. I have never successfully done a cannabis clinical trial in patients with cancer. So we had to modify that protocol. So it was patients with any pain on any and on twice a day sustained release morphine or sustained release oxycodone. And again, we did not find any clinically significant changes in the pharmacokinetics with vaporized cannabis. Now, taking an oral solution, a capsule, or very popular in the past here in San Francisco were these highly concentrated oils, where patients were told by the internet or some sort of social media that they could cure their cancer if they took these very high dosage of CBD or THC. And there I did see I think I saw a significant pharmacokinetic interaction, especially in a patient being treated for myeloma with oral agents, taking a highly concentrated CBD oil. That patient became very cytopenic. All their blood cells were really knocked out way more than the oncologist thought they should be. And I said, CBD, I think, is probably causing toxicity, buildup of those agents in the bloodstream by impacting the enzymes that you were talking about in the liver. But otherwise, I don't think inhaling cannabis, I don't think you're going to really impact pharmacokinetics that much. And again, we just haven't done enough really rigid pharmaceutical studies to answer that question.
I think for me, my worry most of the time is patients on maybe warfarin or tamoxifen or immunotherapy agents on CBD. There's a common belief that CBD is safe because it's not psychoactive. Obviously, from a 450 standpoint, CBD is actually a potent inhibitor of several CYP enzymes, which you'd mentioned, because I think this surprises a lot of patients who thinks CBD is essentially harmless. But I think we need to do more studies to see patients, even if not on just cancer medications, that what interacts with whatever medications they are taking apart from cancer patients that could interact and make dangerously side effects for them and may probably worsen the situation they were in, thinking they're helping themselves, but obviously not. So now, Dr. Abrams, does timing of cannabis use relative to chemotherapy, does it change the clinical picture?
I'm sorry, does it change the clinical picture?
Yes, like timing of when you take your chemo drugs and cannabis.
So, again, as I mentioned, as an oncologist here in San Francisco, I would guess that 40% of the patients that I've seen getting chemotherapy are using cannabis, either for pain, sleep, nausea, appetite. Cannabis is the only antiemetic that also increases appetite or anxiety, depression. So I don't worry about my patients getting chemotherapy using cannabis, hormonal therapies. The one group that I am a little concerned about are patients getting the new immunotherapies, the checkpoint inhibitors. And that's mainly because of two large retrospective studies coming from Israel. In Israel, if a patient gets cannabis, they get a license, which allows them to be surveyed over the course of time. And two studies from Israel suggested that patients who use immunotherapy and who use cannabis while they're getting immunotherapy not only have worse outcomes, but decreased survival, like a 2-year survival difference, which is incredible to attribute that to cannabis itself. But that's what they did. Now, since that time, there have been some ongoing prospective studies done here in the United States of patients on immunotherapy using cannabis showing no such harm. But I don't know what to make of it yet. So I do caution patients on immunotherapy about the Israeli data, and I show them the survival curves so that they can make their own decision.
Yeah. I think another question I have for you, I know you said you don't think it matters, but let's say a patient is using cannabis to manage nausea and they have a chemo infusion, let's say on Thursday. should they use cannabis the night before, the morning off, after? Does it matter?
I don't think it matters. I mean, yeah, I would probably I mean, I've never asked a patient what when they use it in, association with their infusion, but I would think probably just like we give antiemetics by vein before we give the chemo, I
Mm-hmm.
would use a little cannabis before and then after.
Yeah.
Yeah,
Yeah.
that's but
Right.
I've never had chemo, thank goodness, but, I'd have to ask one of my patients how they find that works best. But,
Okay.
I was a member of the American Society for Clinical Oncology committee that came up with guidelines on the use of cannabis, and I will say that those guidelines are very, very conservative. And why
Mm-hmm.
is that? Well, because there's not a lot of randomized, prospective, placebo-controlled trial data out there in the literature because cannabis, up until a week ago or something, was still a Schedule 1 substance according to the federal government. Schedule 1 means high potential for abuse and no accepted medical use. And Schedule 1 substances are so difficult to study. Again, as I mentioned, the only legal source up until recently was the National Institute on Drug Abuse, and their cannabis was nowhere near the strength of the cannabis that our patients access in dispensaries here in San Francisco. So it's
Mm-hmm.
sort of like apples and oranges, but
Okay.
it worked. People always say to me, it was that good cannabis at all that you got from the government. Well, it worked. I mean, I was able to, show evidence of some sort of fact that the patients were being exposed to actual cannabis.
Interesting. So,
Mhm.
nausea and vomiting. The symptoms most patients most commonly cite when they turn to cannabis, and we already know that we have antiemetics. You mentioned ondansetron, dexamethasone, chlorpromazine. Where does cannabis fit along those? Should it be a replacement? Should it be a complement or last resort?
Yeah. Well, it's interesting that I just gave a lecture and I had to re-review these surveys. There are a million surveys now of cannabis use among cancer patients in Memorial Sloan Kettering, MD Anderson, Oklahoma. Everybody's reporting on papers. And it's interesting that usually nausea and vomiting is not the number one reason. Number
Mhm.
one is usually pain, and then sleep, and then anxiety, and then appetite, and then nausea. Yeah.
You beat
And
me
it's
to it.
probably
I was about.
yeah,
Go
probably
ahead.
because we have so many antiemetics that works. Patients don't, if they can tolerate the constipation, don't necessarily think of cannabis as,
Mm, the
yeah.
option.
But I mean, on the other hand, cannabis became legal for everybody in California in 2018. But before 2018, for medical use, I had to write a patient a letter every year. And I
Mm,
have an email from one of my patients that I use as a slide when I lecture about cannabis to medical professionals. He
yeah.
said he was 48 years old, had metastatic colon cancer, and he
Mm,
thanked me for giving the opportunity to use cannabis. He said he didn't use it until his fifth cycle, him getting
mm,
over the stigma of its use. But he said
mm,
it did what no other antiemetic could do. It allowed
mm,
him to feel perfectly normal, to play with his children, and to lead a normal life. He said
mm.
now he's on a chemo vacation because his scans were clear, but he
Wow.
would like me to renew his letter so that he could use cannabis instead of a sleeping pill because it
Mm,
works very well and he prefers cannabis to the zolpidem.
mm.
So
See.
yeah,
Yeah.
it's I have one botanical that I could recommend for sleep, nausea, vomiting, pain, anxiety, and depression. Instead of writing prescriptions for four or
Different
five
prescription
medications
medications.
that all might
Mm,
interact with each other or with the chemotherapy that the patient is getting. So it's a
mm,
very versatile and very safe
mm.
botanical.
Yeah.
I mean, now we rescheduled it from Schedule 1. I mean, the
To
president signed a executive order, as he does with many things, so it went from Schedule 1 to Schedule 3. My belief is that
interesting.
cannabis is a useful botanical, safe, that's been used for 3,000 years, and
Mm.
patients should be able to access it like saw palmetto or echinacea, but it should be regulated like tobacco and alcohol. So I
I
don't
was
think
gonna say that.
there's not a need to interpose a physician between the patient and their medicine.
Yeah, I was gonna say I think it should be regulated, and then you beat me to the punch because I was gonna say beyond nausea, pain and sleep disruption. I know there are two big major issues for cancer patients. And you've stated that you know that at least cannabis deals with 4 different things: the pain, the nausea, the pain, nausea. You mentioned 2 other things that if one
Anxiety,
thing can,
depression, and sleep.
anxiety and depression, and if one thing can handle those 4, I think it's a pretty strong and a pretty good thing. The evidence for cannabis in these areas are strong as it is for nausea. Are we cannabis used to help cancer patients? Are we moving forward as a country apart from California in terms of helping people? Like you said, we have from Schedule 1 to Schedule 3. That's a movement forward
Yeah.
for cancer patients. Are we moving as a country, or is just the state of California? Do you see progressing with this?
Well, I think, again, we just signed the executive order moving cannabis from Schedule 1 to Schedule 3. So
Yeah.
hopefully that will make it more widely available for patients with cancer and with other problems as well. I think the majority of states now have cannabis available either for medical use or medical and recreational use. I think
Yes.
there are only 12 states that where cannabis is still unavailable. And of course, it's probably available underground there in those states as well. So, I mean, you ask a question that, again, as I mentioned, I was a member of the American Society for Clinical Oncology Guidelines Committee, and I was a little bit troubled by how conservative our guidelines are because there's just not enough data from randomized, double blind, placebo
Yes.
controlled trials of cannabis. And Elana Braun at Harvard, who was the chairman of the committee, did a survey of oncologists published in the Journal of Clinical Oncology. I believe it was in 2018. And she had 400 oncologists respond. 80% said they talked to their patients about cannabis.
Mm.
Only 78% said those discussions were patient initiated. 2/3 thought cannabis was useful for appetite and pain. Less than 50% ever recommended it, and only 30% thought that they knew enough about it to recommend it. So
Mm.
again, I believe that this is a useful botanical. You don't need a package insert. Most patients can figure out how to use cannabis to benefit their symptoms. I mean, the mantra is start low and go slow,
Yeah.
which is not grammatically correct because it should be start low and go slowly. But
Mm.
anyway, start at a low dose and then increase it until you get the relief of the symptom that you're trying to treat.
That's interesting because everything you've described so far depend on starting slow, the drug, the dose, the timing, the delivery, and the individual patient. But I know that most patients are navigating this completely alone, probably sometimes without telling their doctors. So I think we need to talk about that. It's probably the elephant in the room: patient disclosure, patient responsibility, patients trying to navigate either to tell their doctor or not. I know studies suggest that somewhere between 25 and 40% of cancer patients use cannabis during treatment. They do not disclose to their oncologist. From your
20%,
clinical to
20%,
20%? 20. Okay.
20% disclosed. Yeah. Yeah. Yeah.
So
Yeah.
from your eye, what do you think is driving that silence?
Well, again, as my patient wrote in that email, the stigma of its use. So the patient didn't use it until his 5th cycle of Folfox because he thought cannabis was associated with stigma. And the patients don't want to tell their oncologist because of the stigma, or they fear that their oncologist will say, oh, if you're using cannabis, I don't want to take care of you anymore.
Yeah.
I don't, I think that would be very unlikely in the 21st century. But
Mm.
I live in a bubble. San Francisco is not the rest of the world. I appreciate that. We're sort of unique here.
I think so too. But I think part of it is on the patients. But I know that most of it is on us as clinicians. Because if a patient is afraid to tell their doctor, that is communication failure somewhere in that relationship. So what do you think oncologists and pharmacists should be doing differently to open that door?
Well, I mean, when I see a new patient, say, it already gets pre-populated in my electronic medical record because they've already seen somebody and asked about their tobacco and alcohol use. So
Mm-hmm.
after tobacco and alcohol, I ask about cannabis and just one, two, three, just make it as like, personally, I believe tobacco and alcohol are much more harmful than cannabis. So I just make it part of my questioning. Or you can do it when you ask about supplements. Are you taking any vitamins? Do you take any minerals? Do you take any other supplements? Do you use cannabis? Just matter of factly ask the
Yeah.
question.
That's quite I think it should be a way forward, and I'll bring in a pharmacist perspective here, because the pharmacist is often the most accessible member of the healthcare team. A patient can walk in without an appointment. So what role should pharmacists also be playing in this cannabis conversations? I understand with the doctors, they can fill a questionnaire, like we do when we go to the doctor's office. How do we as pharmacists do?
A number of years ago, two graduates from the University of California, San Francisco School of Pharmacy came to my office and said, "What would you think if we opened a dispensary?" And I
Hmm.
said, "That would be great." They came back a year later and told me it cost $1 million down to open a dispensary. So instead,
Hmm.
they were doing an online cannabis concierge practice where I
Hmm.
could refer them patients and the patients would get in touch with them. And for a fee, they would tell them what medications they were on, what cancer they had, what their treatment was, and what they were trying to treat. And the pharmacist would recommend a tincture that they thought would work best. I believe that in Connecticut, the dispensaries are all manned by pharmacists. So pharmacists
Hmm.
are present in the dispensaries.
Yeah.
During COVID, when I was at home, my husband wrote the book Marijuana Gateway to Health: How Cannabis Protects Us from Cancer and Alzheimer's. And when I was at home doing consults from the house during COVID, he would come in and say, "You sound ridiculous telling these patients to ask the bud tender at the dispensary what works best." And I said, "Why? They're on the front lines, they're selling the
Mhm.
products. They must know what's better for nausea, what's better for sleep." He said, "They don't,
Yeah.
they're not trained." So again, a pharmacist, it would be great to have pharmacists available, in dispensaries or in oncology clinics and to look for drug interactions. But again, we just don't know enough about cannabis because of its Schedule 1 status to really know what clinically significant pharmaceutical or
Interactions.
pharmacokinetic interactions exist.
Yeah. Yeah.
Yeah.
One of the things I hear most from patients is that they do not know what questions to ask or what to even look out for. I know that it's a part I wrote, Food That Clash Your is a guide that it meant to have these exact conversations, the ones patients are not having with their healthcare team, what they need to know before they do. My book is available at PharmaPlan Systems, and but more than the book, I just want patients to feel empowered to have the conversations. Dr. Abrams, if you could give one piece of guidance to a cancer patient who's already using cannabis and has not told the oncologist, what would you say? How do they approach the oncologist?
How do they approach their oncologist to
Or how
discuss
do
with,
they tell their, yes, what would be a
again,
easy way if,
from a Abrams study, she found that 78% of the discussions about cannabis were patient or initiated. So I think
hmm,
patients probably know how to have this discussion with their oncologist. I would say that I would ask the oncologist what they think about using cannabis, perhaps for my nausea, for my pain, for my anxiety, for my insomnia, and the oncologist would probably say, "I don't know, try it," or "No, don't do that." Just like they say with all the supplements that I tell my patients to take, "No, don't do that. It'll make your liver damage." I said, "Oh, and your chemo is not gonna damage the liver?" Of course it did. So, I think being honest and open, I think it used to be don't ask, don't tell, but now it should
hmm,
be ask and tell.
I
Doctor
do
should ask
agree.
the patient, and the patient should tell the doctor.
I do agree. Full disclosure. That's how we can take care of you fully.
Yeah.
So, Dr. Abrams, we always close with a rapid fire round. The short answers, first instinct. Are you ready?
I hope so.
Okay. So my first question would be, what is the most common side effect of cannabis you see in patients, in cancer patients?
Getting high, euphoria, dizziness, fatigue, dry mouth, red eyes. Older people, and especially with cardiac disease, are patients that I'm more cautious with because, cannabis can make your blood pressure go
12.
your pulse can go up or down, your blood pressure can go up or down, and an older person with cardiac disease might stand up and then fall down and break their hip, and that wouldn't be good.
Yeah.
So, but otherwise, I think the major side effect is getting high.
If a patient can only choose one, CBD or THC for nausea and pain.
They did a study in the Netherlands where they have three different types of cannabis available in their pharmacies. Two of them high THC and one is Valence THC CBD. And the ones that worked for nausea were the high THC. CBD did not do anything.
Much. One thing you wish every oncologist knew about cannabis today.
That they're not going to find the evidence that they usually demand for treating a patient with cancer. Cancer is a very serious illness, and we use very, very serious drugs. And all of those drugs have been submitted to randomized, placebo controlled, double blind prospective studies. Cannabis, because of its Schedule 1 status, has not achieved that sort of evidence base. They just need to know that it works. It's a useful intervention for people that benefit from it. I mean,
Edibles
I heard today that my husband told me he read the New York Times that the American Pain Association said cannabis should not be used for pain. They similarly said something about CBD, very similar a while back. They wrote a big piece in one of their journals, but how can they say it shouldn't be used for pain when the whole reason we have this system of cannabinoid receptors and endogenous cannabinoids is to help us modulate the response to noxious stimuli or pain. I mean, people say that the reason women will have a second baby is because of the cannabinoids, endocannabinoids, and cannabinoid receptors. It helps them to forget pain.
The pain. Yes, because you always say no, never again, and then you're there you again with another kid. Edibles or tinctures for consistent, predictable dosing. Which one would you prefer?
Yeah, as I mentioned, I prefer tinctures because edibles take too long, and the tinctures you get an immediate bump, and the edibles are all sugar,
Okay.
and sugar and cancer, no.
Don't go along.
Yeah.
Myths about cancer and cannabis you would like to put to rest right now.
Well, that cannabis cures cancer. I mean, there's in vitro evidence and animal studies that suggest that cannabis and cannabinoids may have some activity against cancer cells in the test tube or transplanted into mice. But the percentage of those studies that translate into pharmaceutically approved anti-cancer agents is about 5%. So just because it happens in the test tube in mice does not mean it's going to happen in people. And for me, it was very sad when I used to see patients with a potentially curable malignancy waiting 8 months to see me treating themselves with a highly concentrated oil of cannabis, thinking that they were going to cure their cancer, and now they have metastatic disease. So
That's so
cannabis
sad.
does not cure cancer.
Quite sad. I think this has been exactly the conversation I hoped it would be. Honest, evidence based, and genuinely useful for patients who need it most. So, thank you for your decades of work that most of your colleagues were not willing to do. It matters more than you know. And to our listeners here, I think there are three takeaways from today. For me, one, CBD and THC are not interchangeable. They work differently in the body. They interact with medications differently. And the delivery method changes everything. So do not assume that because if something is natural, sometimes it's safe. Not always safe alongside chemotherapy. Number two, cannabis interacts with the cytochrome P enzyme system. That same system that metabolizes most chemotherapy drugs. So if you're using cannabis during cancer treatment, your oncologist and your pharmacist needs to know. And not because they will judge you, but because the interactions could affect whether your treatment works, which is quite important. I think number three, you deserve a healthcare team that would have this conversation with you without shame. If your team is not having it, ask for it. You have every right to that conversation. For more on food and medication interactions, including how what you eat can affect your cancer medications, visit PharmaPlan Systems. My book, Foods That Clash with Your Prescription, is also available on PharmaPlan and the MediMeal Save app, which gives you the real-time food-drug interactions a lot. And I want to thank Dr. Abrams. I want to know, Dr. Abrams, where can people reach out to you if you have questions so we can put it in our show notes?
No, I don't need people reaching out to me. I'm retired. Thank you. I'm retired.
Thank you so much, Dr. Abrams. Sure, you can find everything at PharmaPlanSystem.com. Find us on Instagram, Facebook, Threads, and TikTok at MedimyoSafe, on YouTube at PharmaPlan Systems, and on LinkedIn. So subscribe wherever you listen to podcasts. And if today's episode helped you, share with someone who needs it. Until next time, this is Dr. Remi reminding you it's smart, your meds matter, and your body will love you for it.